Hello, my name is Carol Zambrano. My topic is Ribaroxovan in patients with heart failure, sinus, rim, and coronary side. Definition. Ribaroxavan is an oral direct factor inhibitor that reduces thrombus generation. The treatment improves outcomes for patients with worsening chronic heart failure and coronary artery disease. Since heart failure is associated with activation of thrombotic relief pathways, which predict a poor prognosis.
So in this chapter, chapter 6, cardiology, we'll be specifically focusing on our anticoagulants. The 4 different groups of anticoagulants that will be focused in this video are going to be our unfractionated heparin, commonly just referred to as heparin, our low molecular weight heparin, and an example of that is our enoxaparin. That's the generic, and the brand name is Lovenox. Then we have our vitamin K antagonist, commonly known as warfarin, and one of the brand names for that is Coumadin. And then last we have our factor 10A inhibitor, and an example of that is going to be Ribaroxovan, the brand name for that, Xarelto. So for our first practice question, we have a blood thinning medication that does not require renal adjustments and has a rapid onset of action. Is that A, our unfractionated heparin, B, our low molecular weight heparin, enoxaparin, brand name Lovenox, C, our vitamin K antagonist, warfarin, brand name Coumadin, or D, our factor 10A inhibitor, Rivaroxaban, brand name Xarelto. That's going to be A, heparin. So no renal adjustments are necessary with heparin, and this does have a rapid onset of action. So our enoxaparin and our Rivaroxaban are both going to need renal adjustments, and specifically our Rivaroxaban or our 10A inhibitor is going to be contraindicated in patients that have severe renal dysfunction. Both warfarin and heparin do not require renal adjustments. However, warfarin has a delayed onset of action, and it can take several days until it can reach its maximum effects. So that is why A is correct in this question. The next question is focusing on our low molecular weight heparin, enoxaparin. So which of the following medications can be taken at home and is administered via injection? So again, that's going to be our enoxaparin or our low molecular weight heparin. So heparin itself is not used outpatient. It's just used in the inpatient setting while it is still an injection. Then we have our enoxaparin, which is an injection that's administered subcutaneously, and it can be used outpatient. Warfarin and Rivaroxaban, while they're both used outpatient, they are only oral formulations. Interacts with green leafy vegetables and requires the most monitoring. So our green leafy vegetables are going to help our blood clot. So specifically, warfarin works to decrease our vitamin K factors, specifically 2, 7, 9, and 10. So warfarin in this case is going to interact with a lot of our green leafy vegetables. And it's not that patients can't have these green leafy vegetables, it's just that we want to make sure that they're keeping the amounts that they have from week to week consistent.
Uses applied in Ecuador. In Ecuador, the main limitation of the administration of Ribaroxavan is the cost, which is why studies were conducted to demonstrate the cost effective of using this drug compared with the traditional treatment of warfarin. Conclusion. Ribaroxavan it dose of 25 mg twice that was not associated with a significantly lower rate of death myocardial infarction or strong the placebo among patients with worsening chronic heart failure, reduced left ventricular ejection fraction, coronary artery disease, and no atrial fibrillation.
Whether they are called novel oral anticoagulants or, as they're trying to move to now in the U.S. and in many cases, direct oral anticoagulants. They are certainly still a hot topic at meetings such as the American Heart Association. And I'm talking with Conchetta Crivera, who is a PharmD and an MPH and a director within Janssen. And we're talking costs here. There's a presentation at this meeting, and we're talking about costs of Ribaroxovan compared to warfarin, correct?
That's correct.
So this is a pretty large study, what, 4,500 patients?
Yeah, we looked at 4,500 patients using the Humana database, which includes commercial and Medicare insurance members. And we looked longitudinally. So these are new start Ribaroxavan patients. And we took a look at longitudinally at their total cost of care, which we feel is really a contribution to the literature because of the fact that recently published Ribaroxavan data has really just shown about the hospital costs, kind of isolating that.
Right.
But what we decided to do was look at the total cost, include the cost of warfarin, which is pennies, include the cost of Ribaroxavan, and really take a look at what's the total overall cost when you look holistically at outpatient, inpatient, ER, and then the pharmacy costs.
And what did you find?
We found that when you include the pharmacy costs, we actually found when you're looking at all cause and AF related, that it's comparable between Riva and warfarin. So that is really the take-home message, and very exciting when we're comparing an agent which is a newer factor 10A oral anticoagulant compared to a generic warfarin.
So what is this going to tell us in terms of more widespread use? For a while there was a concern that it wasn't being adopted fast enough. These new agents weren't being adopted fast enough in the United States. Now it does look like they're starting to move, correct?
Yeah. So there's been misconceptions that, warfarin, the pennies a day, but what we really need to, and this study shows this in the real world setting, looking at hospital pharmacy claims, medical claims across the spectrum of patients, that you really need to take the entire healthcare landscape. You should really look at hospital costs. You should look at outpatient visits, because it all makes a contribution at the end into the total overall cost of care.
So what else are you going to be doing? Are you following this up and doing more analyses?
Well, yeah, so Janssen is really, we're going to be publishing this data, and we have a commitment to real world effectiveness, real world data, looking at these claims databases and really bring forth, research questions on the economics and studying of these drugs.
Well, for all of the last couple of years, we've been talking so much about costs. And so it's really nice to hear some positive news and some encouraging news about one of the newer agents.
Yeah, we're very exciting, and this is a contribution to the literature.
Yeah, absolutely. Now, we have a variety of coverage from CardioSource World News and the American Heart Association meeting, so please look for our cover story and other videos here at YouTube and across Jack.
Thank you very much.